Hello everyone, we are the group 3 and today in this video we will be discussing tissue repair. So this is the part 1 of tissue repair where we will be discussing the definition of tissue repair or healing, the definition of regeneration and scar formation, and we will move on to the types of tissues, then understand the mechanism of tissue repair, tissue regeneration, taking liver as an example. Okay. What is tissue repair? So whenever there is a injury in a certain tissue, what can happen? Okay, so inflammation will be there, which helps ward off infectious agents, but then it also needs to restore the tissue back to its normal function. So repair, sometimes called healing, refers to the restoration of tissue architecture and function after an injury. So after an injury, healing is usually a tissue response. It may be to a wound, it may be an inflammatory process in the internal organs, or it may be a cell necropsy in organs incapable to regenerate. So, repair versus healing. So, repair and healing are almost synonymous. When we say synonymous, it's almost the same. So, but in general, repair is we talk about restoration of parenchymal and connective tissue, while healing is when we talk about the restoration of surface epithelium. But still, repair and healing are interchangeably used. Repair occurs via two ways. First is regeneration, which restores normal cells, and second is where there is a connective tissue deposition, which results to scar formation. Okay, so restoration of normal cells in the case of regeneration occurs only in tissue which have the capacity to proliferate. When we say proliferate, it means that it rapidly increasing or multiplying. Okay, whereas scarring occurs in two ways. First is where cells don't have the capacity to proliferate, and in the second scenario or in the second way is where even if the tissue have the capacity to proliferate, if that tissue is very severely damaged, then the part of the tissue will be replaced by normal cells, but the remaining part of the tissue will be replaced by connective tissue, and that is scar formation. Like in here, we can see two types of injury. First is mild superficial injury, which occurs in regeneration, and second is severe injury, which results in scar formation. Okay. Now, let us understand regeneration and scarring in greater detail. So, repair process is dependent on few important things. One is the proliferation of cells, as we already know, and two is the interaction between cells and extracellular matrix. So the proliferation of cells is again further dependent on, they are basically driven by the growth factors. Whereas interaction between cells and extracellular matrix, all these things are dependent on integrity of the extracellular matrix. Okay, so repair process is also dependent on the progenitor cells, or is also dependent in the development of mature cells by the progenitor cells of the stem cells. Now, once we know that the cells do proliferate in the process of repair, so we need to understand what are those cells that which proliferate during the repair process. So there are three important cell types we need to understand. One is remnants of injured tissue, which tries to attempt to restore the normal tissue. Second is the vascular endothelial cells. This is very important because it creates blood vessels for nutrition during the repair process. Third one is the fibroblasts, which synthesize collagen, which essentially forms scar. Now, the ability of tissue repair themselves is determined partly by intrinsic proliferative capacity of the cell and the presence of stem cells. So, before I will proceed to the next slides, first we must do a recap of the cell cycle because we cannot understand what I will be tackling on the next video if we cannot understand the cell cycle. So in the cell cycle, there are two phases. One is the M phase, which is the mitosis phase, which includes mitosis and actually splitting of the cytoplasm or cytokinesis. And second is the interphase, which the cells themselves are growing, replicating DNA, and growing their function, and then the cycle will go on. Okay. So in M phase, this is where cells actually divide to make more cells. But most of the time, cells are in the interphase. So most of the time, they are not actually dividing. Okay. So in the interphase, you have the G1 phase, S phase, and the G2 phase. There are some cells that don't go through the phase because they are actually in the G0 phase, like I said. So G0 phase is a resting phase or a cell cycle arrest. They are still performing cell function, but they're not performing to divide. This may be temporary, and also some may be permanent. So based on these parameters, based on the proliferative capacity of the cells, the tissue in the body are subdivided into three parts. First is labile tissue, which are nothing but are continuously dividing tissue. It contains cells that are continuously being lost and replaced. An example may be hematopoietic cells of the bone marrow, surface epithelium, and picture of an intestinal epithelial cell. And this labile tissue, these are any epithelium, any surface epithelium. These are areas where the cells are continuously being lost and replaced. Okay. So in stable tissues, these are cells that are quiescent or dormant or inactive. They are cells which are in G0 phase in cell cycle. They are minimal proliferative activity. When we say minimal proliferative activity, they only respond to injury or loss of parenchymal cell, parenchymal cell of solid tissue, endothelial cells, fibroblasts, smooth muscle cells, liver, etc. Okay. So in permanent tissue, third part, these are where cells are terminally differentiated. So these cells are terminally differentiated and cannot undergo mitotic division in postnatal life. So an example of this is neurons, cardiac muscles, and skeletal muscles. So when there is an injury in this part of the neurons or cardiac muscles or skeletal muscles, this is replaced by the position of connective tissue, and that is what we call scar. So I have an example here. We have a picture of a large heel myocardial infarct. So here we can see the white parts of these are the position of connective tissue. And here are the normal cells. So in summary, there are three types of cells. One is the labile tissue, which cells are continuously being lost and being replaced. And two is the stable tissue, which is in the quiescent stage. And then they assume to proliferative capacity, they move from G0 to G1 phase in response to injury. And last is the terminal differentiated cells, where they become non-proliferative in the postnatal life. So these are the three types of that tissue that we need to understand for us to know better about the tissue regeneration and repair. Now that we know that cells proliferate, right? So all these cells proliferate by signals. And what are those signals? These signals may be provided by growth factors. Okay, the signals are provided by the growth factors and the extracellular matrix produced by the cells near the site of the damage. Okay, so the growth factors act as signals for cells to proliferate, and these growth factors are produced by the cells near the site of the damage. It acts as a signal for cells to proliferate, and the rest being the epithelial or stromal cells. Now, let us understand in greater detail about the tissue regeneration in taking liver as an example. So, why liver? Well, because liver is an organ which has a remarkable capacity to regenerate. So, liver regenerate occurs in via two ways. If liver can be restored to normal, for example, if you knock out part of the liver in the case of partial hepatectomy, the remaining part of the liver will start proliferating. Okay, so one way to the liver can regenerate is by proliferation of remaining hepatocytes, and the second one is by repopulation by progenitor cells. So in proliferation of remaining hepatocytes, regeneration takes place by the proliferation of the native cells occurs. And one is by priming phase, two is growth phase, three is termination phase. Let us understand a bit detail about this phase. Okay, so in the priming phase, macrophages secretes interleukin-6, which makes the cells responsive to growth factors by expressing the receptors on their surface. Okay, so here we have a macrophage, and we'll let this as an example of a hepatocyte. So the macrophage secretes interleukin-6 in the hepatocytes, which then makes the cells responsive, for the growth factors. So what are the examples of growth factors? It may be hepatocyte growth factors, maybe epidermal growth factors. So yeah, factors. This particular phase where the cells are being primed for them to be receptive for the growth factor is referred as a priming phase. Now, what happens next? So in the second phase the next phase is the growth factor phase. This is where the cells proliferate by the help of growth factors on the prime hepatocytes. Okay, so once the growth factors goes and sits on the receptors, so that is when the cells get signal, and then they move from G0 phase to G1 phase. And after that, the cells will start to proliferate. Okay, so after achieving requisite tissue organ, the cell stops to proliferate and then return back to the G0 phase, and that is called the termination phase. So the factor responsible for the cells to get back to the termination phase is by the set of transforming growth factors, beta family or TGF beta family. So they stop the So the TGF beta family are responsible to get for the cells to get back to the determination phase or the G0 phase. Okay. So now let's take a summary of the regeneration and proliferation. So we understood the proliferation of remaining hepatocyte liver, then understood the regeneration occurs by proliferation of remaining epidural sites by priming phase, growth factor phase, and also the termination phase, right? So if this does not happen, the second way liver can reach regeneration is by repopulation of from the progenitor cells. This is called repopulation from the progenitor cells or the stem cells. So this happens. It happens when the proliferative capacity of the hepatocytes are impaired. So when how does this happen? Well, this happens usually after chronic liver injury or inflammation. So if the injury is severe, this may happen. So that is where progenitor cells um, move in. So what is the role of these progenitor cells? So well, progenitor cells helps them to repopulate.
Good day everyone, I'm Jimina Bulfa and this is the second part of our report tissue repair. So, in this video, we are going to discuss about repair by connective tissue deposition or scar formation. Later we are going to discuss the steps in scar formation, angiogenesis, deposition of connective tissue, features of granulation tissue, and tissue remodeling. So, if the repair cannot be accomplished by regeneration alone, there is scarring. So what is scarring? Scarring happens if the tissue injury is severe or chronic that results in damage to parenchymal cells and epithelia as well as to the connective tissue framework or if non-dividing cells are injured, like the skin cells. So, it is the replacement of the injured cells with connective tissue. In contrast to regeneration, which involves the restitution of tissue components, scar formation is a response that patches the tissue rather than restores it. And next is the steps in scar formation. So here are the steps. The first one is angiogenesis. The second one, formation of granulation tissue. And the third one, remodeling of connective tissue. So we can see over here that this is a normal tissue. And when there is an infection or injury, there is going to be a hemostatic plug which stops the bleeding. And then there's going to be inflammation at the area of the injury. So, this inflammation is to eliminate the offending agent. And then, there's going to be formation of granulation tissue, and then the deposition of connective tissue or scar formation. So, what are the cells involved in scar formation? Macrophages play a central role in repair by clearing offending agents and dead tissue. It is providing growth factors for the proliferation of various cells, and it secretes cytokines that stimulate fibroblast proliferation and connective tissue synthesis and deposition. So these macrophages can be activated in two ways. The first one is the classical or M1, which is are basically inflammatory and microbicidal. And the second one is the alternative or M2, and they are the ones that helps in the repair process. They are anti-inflammatory and induces repair. So the macrophages that are involved in repair are mostly of the alternatively activated or the M2 type. So, repair begins within 24 hours of injury by the emigration of fibroblasts and the induction of fibroblasts and endothelial cell proliferation. By 3 to 5 days, the specialized granulation tissue that is characteristic of healing is apparent. So, to better understand the formation of granulation tissue, we should understand first what is angiogenesis and how it occurs. So, there are two primary mechanisms by which neovascularization can occur: vasculogenesis and angiogenesis. So here are the two types of neovascularization. The first one is vasculogenesis, which is the process of new blood vessel development. It is the de novo vascular formation, meaning from the beginning. It occurs in the embryo. The vessels formed are mesodermal in origin. For example, skeletal muscles, bone, cartilage, joints, connective tissues, muscles, etc. And in angiogenesis, this is the process of new blood vessel development from existing blood vessels. And this is the pre-existing vessels send out capillary buds or sprouts to produce new vessels. This is also an important process in healing. Aside from healing, it is also involved in growth of tumors. So, after knowing the difference between the two, let us now discuss the three important steps of repair by connective tissue, namely angiogenesis, fibrosis, and scar remodeling. So, in the first step is the angiogenesis. In angiogenesis, there are also steps involved. The first step is vasodilation, which is brought about by nitric oxide, which causes increased vascular permeability of the vessels near the site of injury. So, after vasodilation, the parasites which are surrounding the blood vessels, they tend to get separated because of nitric oxide. And then the basement membrane or BM is exposed as shown in the picture, and then you have the VEGF released by adjoining cells which are responsible for angiogenesis. The third step, the VEGF or the vascular endothelial growth factor is released by macrophages or platelets or leukocytes, which diffuses through the basement membrane, thereby converting the endothelial cell into specialized cells with philopodia called tip cells. So, this increases vascular permeability. As we can see here, these are the leading or the tip cells. So, in the fourth step, the tip cells releases chemicals which neutralizes the basement membrane, which are the MMPs or matrix metalloproteinases, which results in the formation of vascular sprout. So, the cells behind the tip cells are called as stalk cells or vascular stalk. So, we can see over here that the vascular stalks are elongated. The fifth step is the migration of endothelial cells toward the area of tissue injury, resulting to the elongation of the stalk. This is brought about by the VEGFA and FGF2. So, the elongation is also assisted by various matrix metalloproteinases which cleaves the extracellular membrane. So, the sixth step is the proliferation of endothelial cells just behind the leading front or tip of the migrating cells. And the seventh step is the remodeling into capillary tubes takes place after proliferation of endothelial cells. We can see that the vacuoles starts to appear inside the endothelial cells. Then these vacuoles coil together to form capillary tubes, which is brought about by angiopoietins 1 and 2. The eighth one is the fusion of tip cells. So, blood vessels 1 and 2 fuse, and once they are fused, they are remodeled into capillary tubes. This happens with the recruitment of periendothelial cells to form the mature vessel. And the last one is the suppression of endothelial proliferation and migration. And later, these capillaries mature with the deposition of the basement membrane. So, after that, the presence of parasites and basement membrane are what makes the blood vessel or capillary mature. So, as a summary of angiogenesis, here are the processes involved. Um, the different growth factors, the signaling pathways, the extracellular membrane proteins, and the enzymes. So, In the growth factors, the VEGFs, mainly VEGFA, stimulates both migration and proliferation of endothelial cells. This promotes vasodilation by stimulating the production of nitric oxide. And the second one is fibroblast growth factors or FGFs, mainly FGF2. This stimulates the proliferation of endothelial cells. This promotes migration of macrophages and fibroblasts to the damaged area, and this stimulates epithelial cell migration to cover epidermal wounds. The third one is the angiopoietins 1 and 2 for the stabilization of vascular endothelium. And the fourth one is PDGF or platelet-derived growth factor, which recruits smooth muscle cells. And the fifth one is the TGF beta or transforming growth factor beta, which enhances extracellular membrane protein production. So in notch signaling, through the crosstalk with VEGF, this pathway regulates the sprouting and branching of new vessels and thus ensures that the new vessels that are formed have the proper spacing to effectively supply the healing tissue with blood. And the next one is the extracellular membrane proteins. These participate in the process of vessel sprouting in angiogenesis, largely through interactions with integrin receptors in endothelial cells and by providing the scaffold for vessel growth. And the last one are the enzymes. In the ECM, notably the matrix metalloproteinases or MMPs, this degrade the ECM to permit remodeling and extension of the vascular tube. So that is how angiogenesis occurs. Next is the deposition of connective tissue, which occurs by two things: the migration and proliferation of fibroblasts into the site of injury, and these fibroblasts deposit matrix proteins, which are basically collagen. These are all brought about by PDGF, fibroblast growth factor 2, and TGF-beta, which are synthesized by macrophages, mast cells, and lymphocytes. And the major sources of these factors are inflammatory cells, particularly M2 or the alternatively activated macrophages, which are present at sites of injury and in granulation tissue. So, what is the transforming growth factor beta or TGF beta? This is the most important cytokine involving tissue repair, particularly scar formation. This stimulates fibroblast migration and proliferation. This increases the synthesis of collagen and fibronectin. In the later stages, it inhibits MPs or metalloproteinases, and by doing so, it decreases the degradation of ECM, which is needed in the remodeling of vascular or newly formed blood vessels were taking place. In the later stages, after blood vessels were formed, the TGF-beta is no longer needed, which inhibits MPs. It inhibits lymphocyte proliferation and leukocyte activity, thereby limiting and terminating the inflammatory response. That is also a reason why the TGF-beta is also referred to as anti-inflammatory cytokine. So, now that we know the steps involved in the formation of newly formed blood vessels by angiogenesis and the deposition of connective tissues by fibroblasts, uh, this results in the formation of granulation tissue, which is the second step in scar formation. So, granulation tissue is a pink, soft granular appearance on the surface of healing wounds, as we can see in the picture. Repair begins early in inflammation, sometimes as early as 24 hours after injury. Fibroblasts and vascular endothelial cells begin to proliferate to form. So, by 3 to 5 days, a specialized type of tissue that is characteristic of healing called granulation tissue appears. So, the term granulation tissue derives from its pink, soft, granular gross appearance on the surface of wounds. The loops of new vessels, when viewed from the surface, have a granular appearance. However, it is the histological features that are characteristic. And these are, so we can see over here that this is the end result of angiogenesis, which is the formation of new blood vessels or capillaries. And we can see that between the vascular spaces, this contains red blood cells. The second one is the presence of connective tissue deposition in the presence of elongated cells or fibroblasts. These are spindle-shaped cells. We can see that the fibroblasts are spindle-shaped. And the third component are inflammatory cells. So, these are the tiny dots in the background. These are lymphocytes, macrophages, and leukocytes. So, they are needed to synthesize and secrete growth factors. So, the last component is edema. These are the spaces between the blood vessels. It is seen because the newly formed blood vessels are very leaky. That is why there is extravasation of plasma into the extravascular space. These new vessels are leaky because of the incompletely formed interendothelial junctions and allow the passage of proteins and red cells into the extravascular space. Therefore, new granulation tissue is often edematous. So, um, later we will see the appearance of a matured granulation tissue. So, what happens during progression of healing? Progressively, there is a decrease in fibroblast proliferation, decrease in blood vessel formation, increased ECM deposition, and increased collagen synthesis, which all result to scar formation. So, some of the fibroblasts in the granulation tissue acquire features of smooth muscles and they transform into myofibroblasts, which helps in scar contraction. So, over here we can see the comparison between a mature and immature granulation tissue. In the first one is the immature one. So, this shows numerous blood vessels, edema, and a loose ECM containing occasional inflammatory cells. So, the collagen or the mature collagen are stained blue. So, minimal collagen pa lang ang makikita at this point. And in the second picture is a trichrome stain of mature scar. It shows dense collagen with only scattered vascular channels. So the second picture is a mature granulation tissue. So we can see the trichrome stain of mature scar showing dense collagen with only scattered vascular channels. Now let us move on to the last step of scar formation, which is the connective tissue remodeling. So the outcome of repair process is influenced by a balance between synthesis and degradation of ECM proteins by MMPs. So after its deposition, the connective tissue in the scar continues to be modified and remodeled. Once the function of MMPs are over, it's stopped by tissue inhibitors of metalloproteinases or TIMPs. So, MMPs include collagenases which cleave fibrillary collagen, gelatinases which degrade amorphous collagen and fibronectin, and stromolysis which degrades a variety of ECM such as proteoglycans. And we can see over here also. So these are the three important MMPs. Now, once the function of MMPs are over, they cannot keep on cleaving collagen. So it has to be stopped, which is brought about by TIMPs. And that is the last step in scar formation. Now, let us have a summary of repair by scar formation. So, tissues are repaired by replacement with connective tissue and scar formation if the injured tissue is not capable of proliferation or if the structural framework is damaged and cannot support regeneration. The main components of connective tissue repair are angiogenesis, migration and proliferation of fibroblasts, collagen synthesis, and connective tissue remodeling. So, repair by connective tissue starts with the formation of granulation tissue and culminates in the laying down of fibrous tissue. So, multiple growth factors stimulate proliferation of cell types involved in repair. TGF-beta is a potent fibrogenic agent. ECM deposition depends on the balance between fibrogenic agents, MMPs, and TIMPs. So, those are the steps in repair by connective tissue deposition or scar formation. And the next report is wound healing.
Hello everyone and welcome to the third part of this video where we will be discussing wound healing. So in this particular topic, we will be discussing the definition of wound healing, classification of wound healing, various factors which affects the wound healing, pathological aspects of wound healing, and also healing of some special tissues. So, the definition of wound healing is this is where mechanism whereby the body attempts to restore the integrity and function of injured part, reform barriers to fluid loss and infection, limit further in entry of foreign organisms and material, and also reestablish the normal blood and lymphatic patterns. So wound healing is a complex but orderly phenomenon. So this process includes initiation of acute inflammatory process, migration and proliferation of epithelial and connective tissues, synthesis of extracellular matrix proteins, remodeling of connective tissue and parenchymal components, and collagenization and acquisition of wound strength. So some terminologies that we need to understand is the acute wounds and chronic wounds. So acute wounds they heal rapidly, while chronic wounds take time to heal. So here we have the classification of wound healing. There are two types to classification. First is by healing by first intention, or it may referred to as primary union, and second is the healing by second intention, or also referred to as secondary union. So healing by first intention. So if the wound is clean, uninfected, particularly example being surgical incision, then the healing is referred to as healing by first intention. So this basically involves the injury on the epithelial layer. So this occurs in a closed wound where there is a minimal loss of tissue, very slightly bleeding, and no contamination. So as a result, epithelial regeneration predominates over fibrosis. So the narrow incisional space immediately fills with clotted blood containing fibrin and blood cells. The dehydration of the surface clot produces a scab to cover and protect the wound. Healing in second intention occurs whenever there is a wound with large defects. It heals by granulation, contraction, and epithelialization. So, when cells or tissue loss is more extensive as an inflammatory ulceration, abscess formation, or even just large wound, the reparative process is more complicated. Okay, so regeneration of parenchymal cell alone cannot restore the original architecture. So as a result, extensive granulation tissue grows inward from the wound margin to complete repair, followed by accumulation of extracellular matrix and scarring. Secondary healing differs from primary healing in several ways. First is the large tissue defects have more fibrin and more necrotic debris and exudates that must be removed. As a result, the inflammatory action is more intense than the primary healing. Okay, so second is the much larger amount of granulation tissue are formed. So larger defect accumulates a great volume of granulation tissue to fill the gap and provide an underlying framework for the regrowth of tissue epithelium. So a greater volume of granulation tissue usually results in greater mass of scar tissue. So and the feature that most clearly differentiate primary from the secondary healing is the phenomenon of wound contraction. For example, in this in this particular example, first is within the 6 weeks, larger skin defects may be reduced to 5 to 10% of their original size, largely due to the contraction. So what is contraction? Well, contraction is due to the presence of myofibroblasts. And these are modified fibroblasts that have many of the ultrastructural and functional feature of contractile. Okay. Now, let us discuss how the skin wound heals by primary or first intention and second intention. This will be 24 hours into a week. Okay, so here in the left picture, we have healing by first intention, and at the right picture, we have a healing by second intention. So healing by first intention. So within the 24 hours, neutrophils are seen at the incision margin migrating towards the fibrin clot. So they release proteolytic enzymes that begins to clear the debris. So basal cells at the cut edge of the epidermis begins to show increased mitotic activity. So healing by second intention in the 24 hours in wound causing large tissue deficits, the fibrin clot is larger, and there is more exudate and necrotic debris in the wound area. So inflammation is more intense because large defects have a greater volume of necrotic debris, exudate, and fibrin that must be removed. So in the next 3 to 7 days, you can see in the picture there is a lot going on in this picture. So in the first intention, so by day 3, neutrophils have been largely replaced by macrophages, and granulation tissue progressively invades the incision space. So over the next 3 to 7 days, there is a formulation of granulation tissue. Like I said, we have discussed in greater details about the process of angiogenesis. So lots and lots of blood vessels starts forming along with the position of these inflammatory cells. So here in the second intention, it starts proliferating, migrating towards one another, approximating, and then it starts to cover. But of course, this might take more time because if there is an infection, then this process might be delayed. So the larger defects have larger granulation tissue, so large amounts of granulation tissue forms in the same 3 to 7 days. Also, blood vessels are larger than the first intention. So within a week, in the first intention, neurovascularization reaches its peak as granulation tissue fills the incisional space. So these new vessels are leaky, they are allowing the passage of plasma proteins and fluids into the extravascular space. So in the first week and subsequent week, there will be a clear-cut deposition of connective tissue in the form of scar. You can easily see that the scar is not really very thick. It's a very thin scar, and then epithelium has completely regenerated. Okay, so this is how wound heals by first intention. when it is clean and uninfected. So here we have in second intention, also in a week. In the next few weeks, just like what we saw in the primary intention, larger proliferation of fibroblasts laying down of collagen, and then this collagen is too much because it is larger scar as compared to wound healing by primary intention. So wound contraction generally occurs in large surface wounds. So the contraction helps close the wound by decreasing the gap between its thermal edges and by reducing the wound surface area. So the initial steps of wound contraction involves the formation at the edge of the wound of a network of myofibroblasts, which are modified fibroblasts exhibiting many of ultrastructural and functional of contractile smooth muscle cells. So you can easily make out that there is a depression on the surface of the wound. Okay, so this is what happens in wound healing by secondary intention. Okay. So classical stage of wound repair. Inflammation, so until 48 hours of injury. So, and in tissue formation, which is 2 to 10 days after an injury, while remodeling is more 1 to 12 months after repair. So here we have inflammatory, then we have proliferative, and then remodeling. So inflammation and proliferation and remodeling, these three phases involve first stage of inflammation, stage of granulation, tissue formation and organization, stage of epithelialization, stage of scar formation and resorption, and lastly is the stage of maturation. So now let us understand what happens to the wound strength. So what happens in the wound strength is that at the end of the first week, you only have 10% of that normal strength. So the wound strength will be only 10% of the normal, which rapidly increased over the next 4 weeks. And then it slows down at the end of the 3 months. The wound strength will be a maximum of 70 to 80% that of normal at the end of the 3 months. So no one can achieve 100% of normal tissue or normal tensile strength. So the maximum wound strength can only be achieved to 70 to 80%. Now, moving on to the next important part, we will be discussing the factors affecting wound healing. So this is classified into local and systemic factor. So in systemic factors, you have nutrition. So in nutrition, low protein levels in the diet have an adverse effect on healing. So in special importance are the two sulfur-containing amino acid methionine and cysteine. So in the absence of these amino acids, connective tissue of weak tensile strength is formed. In protein deficiency, few fibroblasts is formed and resulting to healing retarded. So second is the vitamin C. So deficiency causes poor and delay wound healing. So vitamin C increases the conversion of proline to hydroxylin and lysine to hydroxylysine. Thus, deficiency of vitamin C results in perisynthesis of normal collagen. So the absence of hydroxyproline will result in failure to achieve fibril formation. As a result, fibroblasts produce little collagen, and what is produced is of poor quality. So zinc. So many enzymes such as metalloenzymes and DNA and the RNA polymerase are zinc dependent. So wound healing is delayed in patients with zinc deficiency and is restored to normal by zinc administration. Next is age. Age is one of the most important systematic factors where wound healing is quite rapid, very rapid in younger individual as compared to that elderly individual. So it is generally believed that with advancing age, the rate of healing may be considerably impaired. So an important factors being the inadequate blood supply in the old age due to generalized vascular disease, particularly in humans. Glucocorticoids. So glucocorticoids, what happens is that this inhibits TGF beta. So we have studied that TGF beta in the early videos that this is very important for healing by connective tissue deposition. So they are the ones which stimulates fibroblasts to synthesize collagen. So if there is a decreased fibrosis, that means the only healing might not be proper if there is a glucocorticoid supplementation. Now, let us discuss the local factors. So, local irritants. So, these are such bacterial infection, presence of necrotic debris, pus or foreign bodies in a wound markedly interfere with healing. Infection is the most important local cause of delaying healing. So, the delay wound healing, apart from persistent inflammation, there is the injury is itself persistent. So that's the reason why there is a delay in modeling, particularly whenever there is an infection. So inadequate blood supply. So wounds which have poor blood supply do not heal faster, particularly when you have a patient with atherosclerosis, or when you have a patient with compromised blood supply. Okay, so these are wound healing that might be delayed. So factors of third is the foreign bodies. These are such as unnecessary sutures or fragments of wood, steel, glass, or even bone. These interfere with healing. Lastly, in the local factors, we have the mechanical factors. An example of mechanical factors are early motion of wounds. This can delay the healing of some special tissues. So in epithelium, this can generally regenerate easily. So when the epithelium is lost, repair occurs by proliferation of epithelium from the margin of the wound. In the kidney, however, no new nephrons can be formed. These cells undergo only on hypertrophy. And also, secretory epithelium of plants, however, is usually not replaced. An example being mammary gland, gastric gland, seminiferous tubules, etc. So, mesothelium. So, mesothelium of the serous surface is quickly regenerated. Next is a connective tissue. So, fibroblasts proliferate rapidly, replacing their own kind and also others that are not able to regenerate. So, when the formed connective tissue is young, it is more cellular and rich in young capillaries. With age, it becomes denser and less vascular. Next is cartilage and bones. So due to avascularity, repair in cartilage is very slow and imperfect. This is usually replaced by fibrous tissue. So repair is very good and complete in the bone. Osteoblast playing the key role. Here and next is the tendons and ligaments. This regenerates slowly but completely. Unlike in the cartilage and bone, it is imperfect. And elastic tissue. This is also replaced rather slow, but also complete. In blood vessels, these are easily replaced by newly formed capillaries. However, the muscular coat is rarely added. So, in muscles, so Lost muscles are reunited by fibrous tissue. Skeletal and cardiac muscles never regenerate. So a certain amount of regeneration sometimes occur in smooth muscle cells. So next we have the nerve cell. Um, this cannot be replaced. So once destroyed, it is lost forever. Next is the neuroglia. This proliferate readily in the nerves. If the nerve cells is intact, repair of the peripheral nerves can occur. So when a peripheral nerve is cut, the distal portion first dies but is slowly regenerate by new growth from the proximal end, and although rarely, union can occur between proximal and the original distal end. So the peripheral nerve then undergoes a series of retrogressive changes known as Wallerian degeneration. The axis cylinder becomes fibrillated and disintegrates. So the myelin sheath breaks up into droplets and then is removed by the macrophages and the sheath cells, the latter being converted into phagocytes. That is the end of my presentation. Thank you for listening.
Okay. Hello everyone, my name is Ira Galano. This is the part 4 of tissue repair, and we will discuss about the abnormalities of tissue repair. What are these abnormalities? Complication in tissue repair can arise from abnormalities in any of the basic components of the process, including deficient scar formation, excessive formation of the repair components, and formation of contracture. We already knew about the general aspect of tissue repair. They discuss about how regeneration takes place, about the process of angiogenesis, and the steps in scar formation or wound healing. But if any of these steps go wrong or become abnormal, then that would be the complication or result for abnormalities in tissue repair. The abnormalities in tissue repair could be classified into defect in healing process, excessive cell proliferation, and excessive scarring. The defect in healing process could be classified as wound dehiscence and chronic wounds. Wound dehiscence is a surgery complication where the incision, a cut made during a surgical procedure, reopens, either internally or externally. This usually occurs after surgery, particularly in abdominal surgeries, and also referred to as burst abdomen. What are the causes and risk factors for wound dehiscence? It could be obesity, malnutrition, infections at the surgical incision site, could be vitamin C deficiency where collagen is not laid properly, and could be even vascular insufficiency. What about the precipitating factor? It could be vomiting, cowing, or ileus that can generate mechanical stress on the abdominal wound because it increases the abdominal pressure and the wounds start opening, and that is wound dehiscence. So chronic wounds. This is mostly about ulceration, so let's understand about venous ulcers, arterial ulcers, diabetic ulcers, and pressure sore. Venous ulcers, particularly in venous ulcers is the leg ulcer caused by problems with blood flow in your leg veins. It can be extremely painful and may form on the skin near the varicose veins. Usually they occur above the ankle, particularly in the individual who have varicose veins or congestive to cardiac failure that would result in chronic venous hypertension. This chronic venous hypertension further leads to chronic hypoxia at the site of ulcer, and it could also have uncontrolled inflammation at that site. So because of the two factors, there will be failure to heal, and that will result in the formation of venous ulcer. The arterial ulcer, also known as ischemic ulcers or ischemic wounds, that develop as the result of damage to the arteries due to the lack of blood flow to tissue. They are common caused by peripheral artery disease, particularly in the scenarios of atherosclerosis of peripheral arteries. What happens when there is atherosclerosis? This would lead to ischemia. Then once there is ischemia, that would lead to atrophy and necrosis of the skin and underlying tissues, which might lead to ulcer, the most commonly seen in diabetic patients. Diabetic ulcer. These ulcers are seen in lower extremities, particularly in the feet. These are the factors of diabetic. In the patient will have vascular disease, neuropathy, metabolic abnormalities, and more prone for development of secondary infections. All these things, finally, it leads to epithelial ulceration and excessive granulational tissue. And next is pressure sore. This defines pressure ulcers, also called decubitus ulcer, as injuries to the skin and underlying tissue because of prolonged pressure on the skin. So whenever the patients are immobilized for so long duration, particularly in bedridden patients, for bedridden patients, sore often occur on the shoulder blades, hips, tailbone, lower back, side or back of the head, heels, and ankles. So what happens? There will be prolonged compressions of tissues against a bone that would lead to mechanical and local ischemia. Once there is ischemia, that leads to hypoxia, skin ulceration, and necrosis. So this is the process of pressure sore. Next is excessive cell proliferation. Let's proceed to excessive cell proliferation, and it includes exuberant granulation and exuberant proliferation of fibroblasts. Exuberant granulation, what is this? It is the formation of excessive amount of granulation tissue which protrudes above the level of surrounding skin. It referred to as proud flesh. Just like this. There is protrusion of granulation tissue, so this is referred to as exuberant granulation. What happened in exuberant granulation? Basically, it blocks reepithelialization. What does this mean? You know, the opposite ends of the skin will not able to reepithelialize, and then closure of wound will not happen. How to manage these cases? You have to remove the excess granulation tissue through surgery to permit restoration or epithelial continuity. Exuberant proliferation of fibroblasts. Incisional scars or traumatic injuries may be followed by exuberant proliferation of fibroblasts and other connective tissue. And other connective tissue elements that may in fact recur after excision, which are called desmoids and also referred to as aggressive fibromatosis, which are basically a low-grade tumor. It is in between benign and malignant tumors. So they are considered as low-grade tumors, one of the complications because of excessive proliferation of fibroblasts. And next is excessive scarring. Moving on to excessive scarring, we will discuss one by one. Firstly, hypertrophic scar and keloids. Both hypertrophic scar and keloids are because of excessive accumulation of collagen, and they are both in raised abnormal scar. What are the difference between these two? In the case of hypertrophic scar, the growth is within the confines of the original wound, whereas keloid, they grow behind the borders of the original wound. And hypertrophic scar regress on the size over a period of time, whereas keloid do not regress. So where do you see hypertrophic scar? In the settings of thermal injuries or traumatic injury that involve the deep layer of the dermis, whereas keloid has individual predisposition. This is hypertrophic scar after a burn injury Look at this, it's a raised scar normally. The scar is raised but it is confined within boundaries of given wound. Look at this keloid, this is also abnormal. This also raised scar, but it has gone behind the confines of wound. This is another example showing keloid of the earlobes. Remember, earlobe is one of the most common sites of occurrence of keloid. The last abnormality we will discussing is contracture. Contraction in the site of the wound is a normal process of healing. But whenever there is exaggeration of this process, then that is referred to as contracture. What happens when there is contracture? It deforms the wound and also the surrounding tissues. The most common sites of contractures are palms, soles, and anterior thorax. Usually occurs in the cases of severe burns, just like this. This is a contracture seen in the palms, and this is a case of severe burns. There is deformity of surrounding tissues. Summarizing the whole thing, we discussed about defect in healing process in the form of wound dehiscence and chronic wound, the excessive cell proliferation in the form of exuberant granulation and exuberant fibroblast proliferation, and lastly, the excessive scarring in the form of hypertrophic scar, keloids, and contracture. Thank you for listening.